Margie here. The integrative approach to osteoporosis really works. Around 2 months ago, I had Dr. Kim Millman as a guest on the podcast, and she talked about the functional testing she does and how this helps her discover the root causes of osteoporosis. I got so many compliments on that episode, but people wanted to learn more. So today, Dr. Millman is back. And she's talking about, she goes over 4 case studies where she really pulls it all together so that you can see how the testing, she uses that and what her treatments are and how really just how this approach has improved people's lives. So it's full of so much great information. But before we start, I just want to tell you a little bit about Dr. Millman. She is a Stanford UCSF USC trained functional medicine physician and research scientist. She's the creator of the online program Restore and Rebuild 100 Days to Healthier Bones. And she's been working with patients with osteoporosis using an integrative approach for over 15 years. And her goal is to really help people find their personalized, what they need to do so they can live a long and active life without the worry and fear that they may break a bone and lose their independence. So I'm really excited to share all this great information with you today. So stay tuned. Welcome, Dr. Millman. I'm so happy to have you here. Recently, you did a few talks and we really went through how, as an integrative physician, and you've been working with osteoporosis for over 15 years, what testing you do. And a lot of people were so excited about it and sort of wanted to know how you even put it together. So you and I talked about it, and we decided it would be so helpful to share some case studies, really showing your management and, how this all works. So I'm really excited for you to be here and share this with everybody who's listening. So thanks so much for coming.
Yeah, thanks. I'm really pleased to be here. And I think that going through these different scenarios can help you to determine expectations and different options and see really how different courses of action and treatments have resulted in different improvements in bone strength and bone markers. So I'm excited to share this with you, and I really hope that it's helpful and valuable for you to make a decision that is important for you.
Okay, well, I'm so excited. So you can just get started and share your slides.
So today's discussion is case studies in osteoporosis. So the first case is a 63-year-old female with osteoporosis that was diagnosed in 2016. And she had quite a family history. So her mother had broken her arm at the age of 76, and her surgeon had said that her bones were crumbling. And then at 94, her mom broke her hip and she was never mobile again. And my patient was really felt like this was her genetic fate. And so when she got the diagnosis of osteoporosis, it was really not a surprise to her, but she was really devastated with this diagnosis. And so over a 5-year period of time, her bone density deteriorated quite a bit. And when she came and see me, her last bone density in 2021, her spine was a negative 3.7, and her hips were a little bit better than that, but she had quite moderate to severe osteoporosis. So when she had come to see me, she had already had hyperparathyroidism ruled out. She had a calcium of 9.9, which was on the high side of normal, but her PTH was nice and low. And so when you run these numbers through DivaBoon's hyperparathyroid app, you can see that the calcium is on the high side of normal and the PTH is exactly where it should be. So this really ruled out a diagnosis of hyperparathyroidism. She had normal thyroid function. Her vitamin D at 86 was a little bit high for me, B12 393. I like 750, and glucose was a little bit high at 97. So a lot of the symptoms that she had were really hormonally related. So she had night sweats and hot flashes. She had some anxiety. She had insomnia. She had a low sex drive, and she also had some dizziness and some sugar cravings. She was eating a fairly good diet with minimal sugar and processed foods. She wasn't eating gluten, and she was exercising a couple of times per week. At that time, I was doing urine DPDs as a marker of bone turnover, and hers was normal. And I did some autoimmune testing, and her thyroid antibodies looked fine. Her inflammatory markers looked good, but she did have a high homocysteine level. And anything over 15 for homocysteine is related to a 2.5 increased risk of fracture. And homocysteine is an inflammatory marker, and it's also related to B vitamin deficiencies. And so we knew that that was a point that she needed to work on. When I first see a patient, I want to make sure they don't have a renal leak. This is something where the kidneys are not reabsorbing calcium as well as they should, and anything under 300 is normal. And you should do this without 3 days of supplements, and hers was normal at 170, so that was ruled out.
Homocysteine is something that not everybody gets, but yet it can be so valuable. As you said, such a high increase in fracture rate when people have an elevated homocysteine, as you said, over 15. But what is normal? Because a lot of times, what's optimal that you like to see? A lot of times the test will just, have it in the green, no problem. So what value should people be looking for on their homocysteine?
Well, I like to see homocysteine less than 8. And this is something really that not a lot of mainstream medical doctors are looking at, although most functional medicine doctors will get a homocysteine. But I think it's really important in the context of bone health.
And I think it's such a great marker. And it's not, it's something you can just easily add to your blood work. It's not like a hard test to do or anything like that. Okay, thank you.
No, it's not. So I have a certain way of calculating how much supplementation a person should be on of calcium. And I would say that it's not a one size fits all. If you go to your doctor, you might hear that a woman of a certain age, the RDA is 1,200 milligrams per day, but I don't agree with this. So first of all, the amount of calcium that your intake of calcium should be both dietary and supplemental. So what I have my patients do is to go on to an app called Chronometer and put their diet there and find out how many milligrams of calcium their usual diet is. And then I take either 1,000 or 800. That value is somewhat controversial. So I've been using 800 lately, and 800 milligrams is the total amount. So you would take the 800 minus your dietary amount of calcium. And also when you determine what your dietary calcium is, that you should exclude really high oxalate foods because they're bio-unavailable. These are like spinach and chard and almonds and rhubarb. I have a table on the next slide that shows you some of the top oxalate foods. And so also, I think it's very important to choose a calcium that is very bioavailable. That would include the either calcium dimalate or calcium citrate. So these are some of the high top oxalate foods, and it's best to take these oxalates out of your calculation when you're looking at dietary calcium, because these oxalates bind the calcium and make them very bio-unavailable. For magnesium should be at least half the amount of calcium that you get in your supplements. So in this case, my patient was going to be supplementing with 600 milligrams of calcium, which meant that she needed 300 milligrams of magnesium. And I like the chelated types of magnesium for the best bioavailability. Again, the malate form of minerals is one that I really like. So the magnesium dimalate or magnesium citrate or magnesium L-threonate, or magnesium citrate, they're all very good forms of magnesium. So my patient's initial protocol that I put her on, she was finishing up some calcium citrate. So she got 600 milligrams and magnesium 300 milligrams. For high homocysteine, I used a product called Homocysteine Supreme. And I like 15 milligrams of MK4 for vitamin K2. And I put her on that. And she was on 5,000 IUs of vitamin D, a little bit of maca, which is gentle hormone support. And she was taking collagen. So because a lot of her symptoms were hormonally related, the first thing that I did was did a salivary hormone analysis. And what you can see is that all of her hormones, estradiol, progesterone, testosterone, and DHEA, were all on the low side of normal or actually low. Whenever you're thinking about doing any hormonal support, you should talk to a practitioner who can do a consent and tell you what the overall risks are of hormonal support and also what your individual risks are for hormones. And so I did this with my patient. She had a mother's cousin who had breast cancer, and this was not a first degree relative. So she had no family history of either of any female cancer. And also for surveillance, I'm always making sure that a woman's mammogram is up to date and that she has a gynecologic exam that is up to date or a pelvic ultrasound that shows that she doesn't have any uterine proliferation. So I started her on just very low, gentle hormone support because this is what my patient wanted. So I started her on a little bit of DHEA and very, very low dose bioidentical estrogen and progesterone. And because we switched her to bioidenticals, I stopped the maca. I also did a cortisol analysis because one of the things that she was mentioning was that she was having problems with stress. So when you look at a salivary cortisol, you can see that the green line is optimal and many of the points are good, except for she's got a high cortisol at night, which can explain some of her problems sleeping and also some problems with anxiety later at night. We did a food sensitivity analysis. My favorite is the food zoomers. I look at the peptide level sensitivities because this is the best technology and it is the most accurate and it is the most sensitive. So for her, she had a high reactivity to almonds and cashews and eggs and dairy and a moderate sensitivity to macadamia nuts and Brazil nuts. So I asked for her to avoid these particular foods in her diet because they were causing inflammation. I also added digestive enzymes to her protocol because she was constipated, and I gave her a probiotic called Megaspore. And after a month, her constipation improved and her bowel movements were normal. So on repeat testing, her homocysteine improved, her insulin was optimal, her A1C was improving, and her glucose improved. When I repeated the hormones, everything had come up. Now, it's okay that the progesterone was high because progesterone is very difficult to measure in saliva, but I was happy with the improvement in both her hormones and her symptoms. Her hot flashes has gone from 5 times a night to 1 to 2 times a night. She was sleeping better. She had better energy. She was feeling less stressed, and her mammogram was normal. So after just 11 months, we did a repeat DEXA scan, and she had an improvement in her spine BMD of 3.3%, and the neck of her left hip had also improved, and her total left hip had stabilized. even more important, her symptoms were getting better. Her night sweats were gone. She had great energy. Her dizziness and constipation were gone. And she was really sleeping better. And so we decided at this point she was really missing eggs. And so we reintroduced them. One of the things that I do is I not only look at the 24-hour urine calcium in the beginning of the case without any calcium supplements, but later on, I do it while they're taking their calcium supplements and don't have them stop. And so not only was her urine calcium good without supplements, but it was also good with supplements. So that meant that her calcium supplement dose was correct for her. On repeat testing, her C-telopeptide was a little high at 552. And so this is a bone breakdown marker. So this indicates that she was breaking down her bones too much. And her propeptide of type 1 collagen, or P1NP, which is a bone formation marker, which should be 1/10 of the CTX or better, was actually great. Her DHEA sulfate was a little bit on the low end. Her progesterone and testosterone was looking good. Her estradiol was at 12, and my target was 20 to 35. So I increased her estrogen. Then we repeated her bone density. That was the following year, and she continued to have improvement in her spine, and her hips had stabilized. We got a TBS on this bone density, and she showed partially degraded bone, which was in line with her DEXA scan. She still had some symptoms from stress and anxiety, and her blood sugar was still an issue for her. After being on the higher dose of estrogen, her C-telopeptide came down into the optimal range. So I was really happy with that. And the P1NP stayed at a good range. Her homocysteine had come way down from 15. Her vitamin D was in a better range, which was 50 to 80. Her A1C was creeping up because she was having more problems with sugar, and her HSCRP inflammatory marker looked great. So I encouraged her to minimize her sugar intake and do less stress eating and increase her strength training. But I think what this case study shows is that this was a patient who we did a lot of things. We did food sensitivities. We looked at her hormones. She had gentle hormone support in the beginning, and she got more aggressive as time went on. And we looked at her stress, and we looked at her blood sugar. So we really did so many things to stabilize her bone density and also to improve it by giving her hormones.
So this is so often people don't realize this is possible. They don't realize a lot of times they say, oh, hormones will not increase bone density. It will just, if anything, help stabilize and prevent loss. So by doing all the combination, reducing the inflammation and attacking it, from all the different angles that you do, that you had, great results. So I think it's just so interesting how this whole integrative approach works.
Yeah, I mean, I will say that I think hormones are a game changer, and they do increase bone mineral density. And you also, especially estradiol, decreases CTX. So you remember that the CTX was 500, came down to 337, and that was mainly an increase in estrogen that caused that decrease in CTX. So some people think that estrogen is the bone building hormone, but it is actually the anti-resorptive hormone. So that means that it's going to decrease CTX. And that's a big learning point. And so when I see that a person is on hormones and their CTX is still high, and I look at their blood levels of hormones and they're not at target, I know I've got a ways to go and can bring those hormones up if that's what that woman wants to do, and make even a bigger difference in her bone strength.
Yeah, and I know that's so interesting because people in the class that you teach, I know there were numerous people that when they had increased their estradiol, the same thing happened. So it's, this is not one time. This is something that's really a pattern with the CTX and reducing the bone breakdown with the estradiol. So I think that's fantastic.
Yeah, I see it over and over. All right. So the next case study, the initial workup, this was a 72-year-old woman who was diagnosed in 2007 of osteoporosis, and she had taken Fosamax for a short period of time, and she discontinued it because she was having GI side effects. She also began a strength training with Sherry Betts, and she came to me in 2023 with a pretty severe osteoporosis of the spine and moderate to severe osteoporosis of the neck of the hip. So this was a woman, the predominant symptom that she has was really crippling anxiety. And then the anxiety would cause really debilitating GI problems. So she would get stressed, and even something like traveling would cause her to be in the bathroom for a couple of hours. So if she traveled, she wouldn't eat for a few hours before she would travel. And she was afraid, she was always worried that she would be tied to the bathroom and something might happen. And it really shows this relationship between the sympathetic nervous system, which is running from a tiger, and anxiety. When there's a lot of crippling anxiety, then this really indicates that a person is sympathetic dominant. And then the relationship between the parasympathetic system, which is digestion and rest and healing, they really oppose each other. So if a person is running from a tiger all the time, it's very difficult for proper digestion to happen. And I knew when I heard of her symptoms that I was really going to have to attack the anxiety at the same time as I attacked the GI symptoms. She also had some insomnia, and I think that was related also to the sympathetic dominant situation, migraine headaches, and some lightheadedness. So she had already had quite a large workup. She had had hyperparathyroid ruled out. Her vitamin D was on the really low end of normal. I like at least 50 for immune system and no higher than 80. She had CTXs that were a little bit high. She had a hemoglobin A1C that was normal, a thyroid function that was normal. So she hadn't had bone turnover markers for a few years. And so her CTX optimal is up to 350. People are losing bone. Some people lose bone at 400. Almost everyone is losing bone at 450. So she was in that gray zone area where her CTX was too high. And so I wanted to get some functional labs on her. I wanted a GI map that shows dysbiosis. I wanted food zoomers that show food sensitivities. And I wanted a Dutch for her hormones and her cortisol to show her stress response. But I didn't feel like I could wait because these functional medicine labs take months to come back. So I started empirically treating her for high cortisol and an overgrowth of bacteria. So her GI maps showed an overgrowth of a pathogenic bacteria, a little bit of H. pylori, which I see an awful lot in women and men with osteoporosis. And then this is her good probiotics, and they really looked pretty good, except for one of these strains called Akkermansia, which is getting to be more and more highly recognized as being a very important strain for our gut. She had a couple of different overgrowths in her overgrowth microbes, so I knew she had a fair amount of dysbiosis, which is exactly what I suspected. Her digestion looked pretty good. She had a low secretory IgA, which is the immune system in your gut, which helps to ward off other pathogenic organisms. So I knew I had some work there. And the zonulin, which is a leaky gut marker, that was high. So I use a product, which is a colostrum product to help raise secretory IgA and to help with leaky gut. Her food zoomer results, she had high reactivity to eggs, and she had moderate reactivity to dairy, lima beans, and to potato and wheat. So I asked her to avoid those foods. And very interestingly enough, you can see this correlation between the GI map, which is in the stool, and the food zoomer, which is in the blood. When you look at the intestinal permeability, which is the same as the leaky gut markers, she had an anti-zonulin in the blood. So remember, the zonulin was high in the stool. And so the only way that antibodies to zonulin are going to be high in the blood is if that zonulin goes across the GI membrane and it sees the immune system reacts, and then there are antibodies that cross over into the blood, causing systemic inflammation, and these things can break down your bones. So it's very interesting to see that whole progression from the GI map into the food zoomer. I really find it fascinating. So this was a postmenopausal woman, and the postmenopausal range is this little purple band. So you see that her estradiol, progesterone, and testosterone were all in the postmenopausal range, which is not surprising for her age. But one of the things that was surprising was how high her cortisol was. Basically, almost every single point was abnormally high. And when you look at the total salivary cortisol, it was in fact high too. So this does explain one of the reactions of her body to this constant stress and this constant sympathetic overload. And so I knew that I had to double down on the cortisol. I gave her extra support in addition to what I had started at the beginning of the case, because I knew this was severe and she needed significant support. We did a repeat DEXA after she had been seeing me for about 5 months, and she had been in a strength training program for about 10 months, and her L1 to L4, her spine improved, and her hips also improved by a small amount. Her estrogen we didn't work on, so that was not changed. I knew that I could give her a little more DHEA. Her inflammation looked good. Now her CTX had come way down from 400 in the 400s to 178, which was showing that the cortisol was increasing the CTX, and her really imbalanced dysbiosis and her crippling gut symptoms was really changing her bone turnover markers, causing systemic inflammation. We had already made an impact, which was great. Her sugar looked great and her thyroid looked great. But really, more than anything, what I felt the most rewarded about was in October when she came to see me. She said she hadn't had an IBS episode in 2 months. She was feeling a lot better with stress. She was able to travel. She was able to handle the stress in her job better. She was sleeping much better. And then in December, she said that she felt like a different person and she didn't have any gut issues anymore. And she called it a miracle, and that she had never felt so good in her life. And so it really goes to show that, you can improve your bones, but you can improve your life so much by doing these things.
I love this because I always say, in which originally people give me a look, that a diagnosis of osteoporosis, first of all, it's an opportunity, but also people look back and it's a blessing in disguise. I mean, look, all the things she did, the bones, it's sort of the catalyst to do all these other things that not only improve your bone health, but improve every aspect of your life. And she's exercising and just doing all these wonderful things. And so yeah, that's to me just because the bones are not in isolation, and all these things that you're doing, for the bones again are just so wonderful. So I love this, and how nice to miracle, this diagnosis of osteoporosis. Look what happened.
Yeah, yeah. And so one of the things that Margie and I have really seen is that it's taken me 15 years to have this expertise in these bone markers, and to really over this period, I've developed this expertise in knowing what the optimal ranges should be, in understanding what are really crucial markers to look at. And sometimes it can be a little bit overwhelming. So I have a program called Restore and Rebuild 100 Days to Healthier Bones, and where I teach all of this. And what I did for my students is I put together a testing tool. And this testing tool actually has all the bone turnover markers and the optimal ranges, and you can actually put in your own values into the testing tool, and then the date that you did them, and the interface and the algorithm will actually calculate whether you need to do them over again. And what I've found is that a lot of my new patients are coming in with the testing tool filled out for me. And it's just a great tool. And so Margie and I wanted to offer this for free for anybody who's on the podcast. And you can go over to the millmanclinic.com/bones testing. And I've just gotten such good feedback on this testing tool. And I love it because it just really cuts down the guesswork of what you need to test, and whether your labs are within optimal ranges or not. And Margie, I think you probably understand that, our conventional counterparts, medical counterparts, they just don't understand some of these optimal ranges. And it's not their fault. It's just that they don't have the training and the experience in it. So I think it also could help to teach physicians as well.
I so agree, because the truth is, just like you said, it's not that they don't want to do this, it's just not their training. And so they have the basic tests that they do. But then when you introduce them to this and you bring this in, you can see, because you have to feel that you're working with a person who is on your side and going to work with you. So it also, I think it's really, a lot of people have learned so much from this testing tool, and it just it makes it easy. That's what I love, because, you're like, okay, because a lot of people will just look at their labs. Okay, it's green, it's green, it's green, it's normal, but
Yeah.
normal and optimal are not the same. And this way you can look and you have all the values that you've worked 15 years to figure out what works and what doesn't work. But so many people have thanked me so much for this tool and have found it so valuable. So thank you for offering it, because it really is wonderful.
Yeah. And then, if somebody wants to delve even deeper and really go into the kinds of analyses that I do in my private practice, I mean, I know that there aren't many, especially MDs out there, who have this kind of expertise and experience, especially with the functional medicine labs, and then what to do with the bone turnover markers, how to correlate them. Then I have a program, and it is called Restore and Rebuild 100 Days to Healthier Bones. And we just opened up the third cohort, and it starts August 17th. And Margie is a co-teacher and co-developer in this program. It's a 14-week program with 11 weeks of content, 11 live Q&As. I've already had people tell me that the handouts and the resources are incredible, and they I've spent a long time producing them. And really, I'm walking people through the science of why is blood sugar important for your bones? What kind of increased fracture risk does it cause? What are these other root cause factors that you want to understand? It does go through the testing in detail, how to interpret, and then my tried and true protocols for interventions, and then how to retest and how to, have a plan moving forward. And so, Margie, you co-teach this. Your favorite module is happiness, and
it's true. The stress, which you'll hear about in the two case and more about in other case studies, but both Dr. Millman and I know how important it is to figure out what, that this piece of with cortisol and increased anxiety, where that plays. So I have a whole module on stress reduction and happiness, as well as exercise. What do we need to do to really move the dial? But this program, it was actually, I don't even know how many years ago I had said to Dr. Millman, because too many people, that unfortunately, there's only one of you, and people are looking for an integrative doctor, and they're trying to, how can I don't live in California. I can't work with you. What are options? And so you really effectively figured out a way that people can do the testing and do this in a group setting and really get benefits. And I think it's the Q&A where you really help people move along with the program. But anyway, yeah, we just wanted to let you know that this is available, and it's for the person that wants an integrative approach and isn't really able to do that. And also it's much less expensive, obviously, doing it in a group program.
Yeah, and just wants to take that next step, right? Not everyone will, but we'd love to have you join us. And you can go to themillmanclinic.com/R&R. And if you use Margie's code, which is HappyBonesF24, you'll get $100 coupon off the $697 early bird price. So getting back to the case studies, we have a 67-year-old woman with a diagnosis of osteoporosis in 2015, and she had a large bone density drop from 2018 to 2021. She also has a history of a renal leak. So that is when your kidneys are not reabsorbing the calcium. And so you really lose a lot of calcium, leach calcium from your bodies. And she was on the conventional medical treatment for that is a diuretic, which she was taking. And she also had a history of kidney stones. So she decided to go the medication route, and she took Evenity, which is one of the new drugs. And she took that from June 2022 to May 2023. It's a once-a-month shot that's given for a year. She had a significant improvement in her bone density in her lumbar spine. She had a 16% increase, and in her the neck of her hip, she had a 6% increase, and the right hip total also a 6% increase. So that is, I will say that it is a pretty incredible response. And so Evenity is an incredibly strong medication. And after she took the Evenity, she now went from severe osteoporosis in her spine to osteopenia. So that was giving her really a lot of confidence that she was going to be able to be active for the rest of her life. This is not the only way to do it, but this was what she decided was best for her. So I wanted to show you a few of the historical values. So evidence of a renal leak is 24-hour urine calcium without calcium supplements, and anything over 300 is a renal leak. She was at 439. And when she went on the diuretic, it tends to decrease your potassium. So her potassium was on the low end of normal, despite the fact that she was on a potassium supplement. Her CTX was high, so anything over 350 is suspicious for losing bone. P1NP was much greater than a tenth, which of CTX, which would be 50. So her P1NP was doing great. Her vitamin D was optimal. And her 24-hour oxalates, remember, this is a woman with kidney stones. So kidney stones are usually calcium oxalates, and this is high. So anything over 30 in the 24-hour oxalate is high, and she was at 40. Citric acid is something that combats oxalates, and her kidney doctor wanted her at 600 or more, and she was down at 276. Her TSH, her thyroid was working normally, and her repeat 24-hour calcium with the diuretic was 273, showing that her diuretic was working, and her PTH was nice and low at 30, which rules out hyperparathyroid. So a lot of her symptoms were related to being on the diuretic. She had frequent urination. She was often thirsty. She had some constipation unless she took psyllium, and she had some symptoms from stress, and she had some insomnia. So we estimated the calcium from her food after we took out her high oxalates, but this is a woman who is actually on a low oxalate diet because of her kidney stones. And this was something that her kidney doctor put her on before she came and saw me. So we estimated the calcium that she was getting from her food was still pretty significant, and she needed only 200 to 400 from supplements. So in this particular case, calcium citrate is the best form of calcium for a person with oxalate problems because of the citrate. So the citric acid combats oxalates. So citrate is citric acid, and that's the preferred form. I changed her collagen over to Perfect Amino. That Perfect Amino is an amino acid blend that helps to build muscle strength and also increase body improve body composition by increasing muscle. One of the things that oxalates do is they deplete minerals. So they bind to calcium, magnesium, potassium, and zinc and deplete them, and also deplete B vitamins, including B6. So I gave her P5P, which is the activated form of B6. I gave her an electrolyte blend called 40,000 volts, which has potassium in it because she needed additional potassium. I switched her over to 15 milligrams of MK4 in Ultra K2. Boron is also something that can reduce the calcium in the urine. So I wanted to also support that. And she was doing a half a cup per day of lemon juice, according to her kidney doctor.
I have a quick question for you before you go. What was the reason that you switched her collagen to the Perfect Amino?
Right. So there's many ways in which oxalates can cause toxicity in the body. So there's too much dietary oxalates coming in. There's not enough degradation of the oxalates from the probiotics in your gut and the commensals in your gut. Also, there's what's called endogenous synthesis of oxalates. And endogenous synthesis of oxalates, you make oxalates, and one of the main things that can increase endogenous synthesis is ascorbic acid and hydroxyproline. So hydroxyproline is found in collagen and bone broth and gelatin. So for this woman who actually had kidney stones, I wanted to not have her do collagen and switch her over to perfect aminos? Yeah, that's a great question.
Thank you.
So when I initially worked her up, we found a lot of things were optimal. Her sugar marker, A1C, and her inflammatory marker. Her homocysteine was great. Her insulin was great. And her ferritin, which is the iron storage form, was a little on the low side. We did a GI map and I found H. pylori, and H. pylori can cause gastritis. It can cause stomach ulcers. So I knew that I needed to treat her for this with some herbal antibacterials. Also, her commensal bacteria were pretty good. She was low in Enterobacter and a little bit low in Akkermansia. As far as her overgrowth, she had 4 red overgrowth. So I knew that what I was using for H. pylori was also going to help with these overgrowth bacteria. She was, her elastase was on the borderline. So I knew she needed some digestive enzymes. And her secretory IgA was low. Remember, this is the immune system in the gut that helps you to ward off other pathogens. And her zonulin was high, which was her leaky gut marker. Again, I gave her a colostrum product that helped to increase the secretory IgA and to decrease the zonulin. So on a repeat workup, we found that her oxalates decreased from 40 to 30, and her citric acid increased to 500. Her 24-hour urine calcium was a little bit on the high side, so I told her to decrease her calcium. This was with calcium supplements, and I do this so that I can see if the calcium dose is appropriate or not. Once I've ruled out a renal leak, then I use this to help adjust the calcium dose. She was feeling more energy with the electrolytes, and she was feeling like her muscle mass was getting better with the perfect aminos. And I found that over and over from people that even if they're sarcopenic, which means that they have a loss of muscle mass, that they really love the perfect aminos. And I find my patients becoming very diligent with their perfect aminos. We did another repeat bone scan, and she continued to improve a little bit. And so from her spine went from 3.4 to 2.2. The right neck of the hip went from 2.9 to 2.6, and the right total hip went from 2.8 to 2.5. So she had an incredible improvement. And so now she feels like she's got the tools in place to keep her bones stable, using making sure that she doesn't have dysbiosis, keeping her stress down, looking at her food sensitivities. So she's got all these tools to keep her bones stable now. And I don't expect that she'll need another course of medication.
No, I think this is such a good illustration of how you can combine both conventional and integrative, because her bone density was very low. She was at a high risk for fracture. The Evenity really got her over the hoop, built bone, while in the same time, you were doing all the work with her on all the root causes and all the other secondary issues going on to cause bone loss. So this just goes to show how when you combine the two, it really works. And so often people are like, no matter what, I'm not going on medications. But these new medications that are anabolic and build bone, there really is a place. Nobody wants to fracture. And I think this is just a good illustration of how you can combine the two of them.
Yeah, and I just think that this was the way that she wanted to go. And I forgot to mention that whenever you use an anabolic like Evenity, you have to come in with an anti-resorptive afterward to take care of the rebound. And so she chose Fosamax, and she was on Fosamax during the period where we were working as well. So that was a component of her medication regimen, but she by the time I think she was pretty much finishing her Fosamax, and she, she comes and sees me as needed at this point because she's really doing great.
Oh, that's wonderful.
So our final and fourth case study is a 64-year-old woman with osteoporosis diagnosed in 2019. She was with another functional medicine practitioner, and they had done what's called a gut zoomer, and the gut zoomer found parasites and also this bacteria, this friendly bacteria called Akkermansia was low. And she has had a history of IBS for over 10 years. She had relatively mild osteoporosis, where it was her spine was worse than her hips. And mainly her symptoms were GI complaints. She had very frequent GI complaints. So she had stomach aches, and she had crampy abdominal pain, and she had soft stools, and sometimes they were frequent, and she had often gas and bloating. So when she first came, she was on a osteosustain. This is a proprietary blend from Dr. McCormick. And I added the 15 milligrams of MK4 twice a day. She was on collagen with Fortivone. I wasn't worried about her being on collagen because she didn't have a huge problem with oxalates like the other patient did. I put her on Akkermansia because I already knew that was low. And another big thing that I did was I treated the parasites in the gut zoomer with an herbal anti-protozoan formula called VRM3. And I did that for 2 months. So this is what I call a killing cycle. And so I did a protozoal killing cycle to treat something that I didn't think was going to go away on its own. So her initial workup, her CTX wasn't that bad, was optimal. P1NP was fine. Her A1C, which is a sugar marker, was on the high side of normal. Homocysteine of 12 is too high for me. Her insulin was good. 2 to 8 is optimal. Her estradiol, when you look at a serum estradiol in a postmenopausal woman, you need to look at a sensitive one. Otherwise, you will get less than 15. Well, that doesn't really help me. So when you get a sensitive estradiol, you find out how much it is. And so her estradiol was very low at 3. Her testosterone was low at 8. And her HSCRP was 1, which is a slightly high, but it wasn't terrible. So I put her on some gentle hormone support with DHEA and maca and some homocysteine supreme. We did a GI map, of course. We had 6 different kinds of bacterial overgrowth. And so after the 2 months of VRM3, I added 2 different antibacterial herbals for the overgrowth. She needed digestive enzymes. She had a problem with her detoxification because of the overgrowth. She had low IgA, so her immune system in her gut wasn't able to ward off the pathogens as well. She had a slightly increased bump in her inflammation, and she had a pretty high zonulin in her stool. So after 6 months of working on the herbal antibacterials, you can see that all of that overgrowth, the 6 different types of bacterial overgrowth they weren't completely gone, but none of them were outside the reference range any longer. So this was a huge, huge improvement in the GI map, and her symptoms showed it as well. The pain, the stomach aches, the soft stools, and the bloating were completely gone. We also showed an increase in her gut health markers. She had good digestive enzyme capacity. Her detoxification was better. Her secretory IgA was much improved. And then her calprotectin inflammation was down to 0. And her zonulin was much improved. But then all of a sudden, she had this response to gliadin. So that is a response to wheat in the stool. So we did a food zoomer, and she was very high in wheat. And so she went off of eggs, and she went off of dairy. This is a repeat after about 6, I think it was actually longer than that. This was a year off of gluten, and she went from 4 down to 0.7. And she didn't stay off of dairy and eggs for that long, so they didn't change that much. And that was her choice. And her intestinal permeability really improved from 5 down to 4. Her repeat labs, her CTX went down even further. Her homocysteine improved, and her estradiol went from 3 to 6. And that was one of the reasons why the CTX improved. And the estradiol improved from 3 to 6 just from a little DHEA, a little bit of maca, and a little bit of boron. Her repeat bone density, she gained 3% in her spine. It may not be statistically significant, but at least her spine was stable and it was not getting worse, and her hips were definitely stable. And she told me that she hadn't felt that good in a long, long time. So that's it for our slideshow.
Yeah, these are great. And these just illustrate so well how this approach, it works. And oftentimes the sad thing is, a lot of times people have all sorts of gut issues and it's not even addressed. So when, both of us believe so wholeheartedly that this is the approach that works, you address the root causes and your bones get better and everything else. So I can't thank you enough. Definitely, this tool is amazing. And as you said, for people who want to learn more, I'm excited about the course. Again, the first time you did the course, even though I teach 2 of the modules, I actually came to every module and I learned so much. It's just a really wonderful course, and it becomes a community as well because there's question and answer, so you really get to know the people. And it's I as I said, it was a long time ago, I asked you any possibility you could pull together, you could do a course. I just think it could be really needed, because I have a hard time. Everybody asks me, like, where can I find an integrative doctor? And unfortunately, there are not many people, especially that have worked 15 years with osteoporosis and have had such incredible results. So anyway, but this is so helpful. So take whatever piece, I'm just, thank you very much for doing this. This is great. Do you want any last minute things you want to share?
Well, I was honored to be here as always. And I am really committed to this community. I've seen the despair, when my new patients come in, and I see the shock and, how could this have happened to me? And I just love the hope, and I love, and I love it when someone turns things around and they feel so much better and they're actually seeing some improvements. And, you can do the CTXs and the P1NPs as often as you want to see them, right? So you can see an improvement in 3 months. You can see, okay, wow, okay, I've got a positive reinforcement that things that I'm doing are working, right? And then when they even just stabilization as an improvement, as you know, and then, people just get excited and that just makes it, I don't know, it makes my job really worthwhile. So I love this community, and I'm grateful to you too, Margie.
It's so interesting because really what I think happens is you go from fear. It's shock, it's fear, it's overwhelm. This diagnosis conjures up all sorts of images, but then we take that fear into what can we do, and into empowerment. And then the empowerment, they become strong. You really deal with so many other issues. You're sleeping better, you're happier, you're less stressed. I mean, it's really taking it from one extreme to the other. And I feel, to me, that's why I do what I do, because it is possible. We both know that. We've both been doing this for so many years, and people just need the tools, and they need tools, guidance, and community. And I think when you have those three things, you're really able to move forward. And so anyway, thank you so much. It's always a pleasure, and I can't wait for the next class. And and also, this tool is just amazing. So make sure you take advantage of this tool, everybody. I hope you enjoyed my interview with Dr. Millman as much as I did, and now have a better understanding of the integrative approach. All the links that Dr. Millman talked about will be in the show notes, including the link to her interactive lab testing tool. So make sure to download that. And thank you so much for tuning in. And I look forward to seeing you on the next episode.